Can you see it?
Yep.
Should we start?
Yeah, I think so. People will join in. Just, you know, take a minute or so to introduce everybody, and we'll let people keep joining in.
Yeah. Okay. So hello everybody. It is my pleasure and privilege to introduce you to our session today on hypothalamic hamartomas. I think it's a very special topic where one simple MRI is potentially able to, identify the problem, but a considerable surgical effort and considerations are necessary to solve the problem. We will start with Dan Carey. He's from Texas Children's Hospital, the director of functional neurosurgery and epilepsy surgery. And then George Dorfmüller, who is the head of the department Fondation Rothschild in Paris. So Dan, please.
All right.
I will share my screen.
Sharing mine. Oops. And all right, can you guys see my slides?
Yeah.
Yeah.
Okay, great. So good morning or afternoon, depending on where you're viewing this from. I'd like to thank the organizers for the invitation to this fascinating epilepsy surgery techniques series, this webinar series. By way of disclosure, I am a consultant to Medtronic and Monteris, the two laser companies, but I'm going to maybe advocate some aspects of their techniques without, being exclusive about it. So when asked to do a webinar about laser ablation hypothalamic hamartoma, which is something I do all the time, I think we should start with why. Why would you do MR-guided laser ablation in hypothalamic hamartoma? But as Christian mentioned, it's actually almost ideal for this in the sense that it's a deep lesion. It's ideal for stereotaxy, in other words. It's a deep lesion. There's a known epileptogenicity, so it doesn't have to do a lot of sorting out to know where the seizures are coming from. It's a known association with epileptic encephalopathy. So these children do have a poor future if you don't intervene on their seizures early on. So this minimally invasive approach should be able to avoid the access-related morbidity, which is really cursed the surgical approach to these deep lesions at the base of the brain.
Excuse me, Dan, I apologize, it's Guy.
Yeah.
We just got a message from one of the participants that there's some issue with seeing the slides clearly. I see them perfectly clearly, but maybe you can unshare and try to check it one more time.
Sure. I'll stop sharing. And I will, oops.
As I said, they're showing up fine on my screen, so I think.
Okay, I'm going to share again. How are we doing? You see my computer anyway? And here's my slides. How's that?
Yeah.
Is anyone else having some trouble?
It's pretty good.
Yeah.
Okay. So where was I? I was talking about minimally invasive approaches. So I'm going to avoid the access-related morbidity. Because it's minimally invasive, it minimizes the hospital stay as opposed to the open approaches. And it's a thermal treatment, so it's immediate effect as opposed to the radiosurgical approaches. Sorry. So why? So there's a number of stereotactic approaches you can do for this. So why would you choose MR-guided lit? So the reason being, it's an MR-compatible component device. It allows the use of near real-time MR thermography to guide you. So the way I see it, it's a truly MR or thermogram guided ablation surgery as opposed to the MR planned surgery, which has been published elsewhere. And it's therefore this allows for an image-based dosing, not just a set RF ablator dosing, and this increases the safety. It increases the safety. You can watch it go, and you can stop it once you're at your borders. So laser ablation in the hypothalamus. It's going to require targeting the lesion with preservation of the surrounding structures. And as you know, it's a very busy area, very low tolerance for the complications. You want to treat the inferior center of the lesion, but adjusting for the heat sinks of the ventricle and the cistern. And you want to have a judicious use of the low limit markers on the memory circuits to prevent the injuries that have been seen in the open approaches. The main complications I'm going to talk about, the big three, are short-term memory problems and Korsakoff syndrome, which is a sudden disability of short-term memory, which has been a big problem. So this usually happens from bilateral injury to the mammillary bodies or the fornices or the mammillothalamic tract. Something in that circuit on either side will cause this problem. The hypothalamic obesity usually is from a ventral median injury. In light microscopy or endoscopic, you sometimes can't tell the difference between the end of the hamartoma and the beginning of the hypothalamus. You can on the MRI scan. And you want to avoid these disturbances of sodium homeostasis, which is diabetes insipidus is the main problem, but that's a rare problem in laser ablation. Cerebral salt wasting is a far bigger one. It usually occurs in large volume ablations in infants. Other complications that have been listed in the stereotactic world have been cranial nerve palsy, such as cranial nerve 3 or 4, and sometimes the optic apparatus. Hemiparesis, due to the proximity of the cerebral peduncle in this area. Disorders of consciousness have occurred, but mainly I think this is a temporary issue in the edema of the reticular activating system. Extraocular movement disorders have been seen as well. This is mainly a tactile thing. And then you get temperature regulation problems as well when you get a lot of edema in your hypothalamus. So to avoid a lot of those, a lot of the secondary ones, I use high-dose steroids, and I think this is the biggest pearl of laser ablation. High-dose steroids is a technique where I can control the hypothalamic edema that can cause this acute memory disorder, intermittent somnolence, and these changes in body temp. Steroids I use are very high dose for children, especially 4 milligrams Q6 for a whole week prior. Seems to tighten up the blood vessels. And I do a 10-day wean afterwards. Why so much? I got this from the high-grade glioma literature. It's relatively old, that allowed a week of steroids prior to safe surgery, so you avoid any other herniations that can occur from opening a very large edematous area. Well, this works well if you do a whole week prior to this, to the ablation. And it may have a temporary weight gain and irritability side effect, but these go away. I was recently shown the utility of this because I had a child who had a fever. And, in the COVID area, we get very worried about that, a fever a few days prior to his operation. So I couldn't use his steroids. So I had to start the steroids just 1 day prior to his ablation. And sure enough, he had the edema of the hypothalamus symptoms. Now he got better, we caught up, but it is a big problem, and it does change the morbidity of these operations. My preoperative imaging is very high resolution, 1 millimeter cuts if I can, especially in the T2 area. A lot of children are hypomyelinated, so some of the structures I can't see, so I use STIRS sequences, and this is an example of a STIRS sequence that can show you a poorly but yet discernible hypomyelinated fornices and the mammillothalamic tracts on this child, so I can avoid them. MR thermography, as I mentioned, is the big key in the safety of this operation. You can watch the heat change in the brain, and then with a software that shows you where things can be ablated, you can make this irreversible damage map cover your lesion as you go, but you can stop it short of going too far. I'm not a physicist. It's something about the chemical shift of proton resonance, but I do know from a practical point of view that this can be prone to drift. So I've always used a marker to look for drift and reset my phase during the operation many times. And also, as a note, it can become quite erratic after diffusion imaging. So if you've done an operation, done the ablation, you look to see where you've done some changes with the diffusion, be wary that that can destabilize your thermogram, and you have to reset the phase a lot. Choice of diffuser tip is important. Early days of laser ablation, this was a 10 millimeter diffuser tip and a temporal lobe. And you can see this is a very large area of high dose heat, but it's very long. So there's going to be many planes in which this ablation is occurring and getting very close to vital structures. So Visualase back in the old days very quickly developed a 3 millimeter diffuser tip, which is ideal for hamartomas. Now it's short and wide, and you only have to study a few planes to look at where any of the lethal heating can be occurring and control it. So the goals in hypothalamic surgery and hypothalamic hamartoma is disconnection first, still. Complete ablation last. And don't be afraid to stage the operations. It may be expensive, it may be a hassle, but you can do the maximal ablation with your corridor and then come back another day for a retargeting. And we've looked at this in our series and we realize if we can get about 60% of the hamartoma, 90% of the patients can be seizure-free. So the go for broke notion of taking out the whole thing is not always needed. It sometimes is, but it's not always needed. Classification schemes of hypothalamic hamartoma, especially in the Delalan disconnection strategy, really doesn't help much in laser ablation. It's more akin to a stereotactic approach. This was the Regi classification score, and it's really good to classify your hamartomas either in the type 1 through 3s, which are easy, the type 6 and mixed, which are harder, and then the type 4s, which are special. Type 5s are usually not needing epilepsy surgery. So my strategy is to target the inferior center of the lesion, to enter the dorsum of the lesion, the top, right between, equal distance between the fornix and the mammillothalamic tract. Follow this vector all the way up to the skull base, or to the skull, to find the actual entry point. Adjust for the heat sink, and I'll show you how to do that, how I do it, and then I adjust for the vasculature. So this is a target, a T2 scan. I look at the very base of this. I put my target right in the middle between the memory circuitry here at the base. And then at the very top, I find the space between the fornix and the mammillothalamic tract, and I go right in the middle of that as my initial entry point. Then I translate that up to the skull base, or to the skull itself. And then I'll do my adjustments for the heat sink. What I tend to do is do a 1/3 diameter along the heat sink and go 1/3 closer to the source where the heat's going to be dissipated, so that heat will go in the opposite direction and fill in the area between the memory circuits. The other aspect of this you want to optimize is there's usually a top to the hypothalamic hamartoma in the sagittal plane. You want to look at that. You want to come down right in the middle of that to maximize your centering of the ablation at the top, where the thermal dynamics are more of a predictable kind. So I start with the assumption of a homogeneous heat dispersion, adjust later for the perceived and suspected heat sinks, and this is not measurable. I create this trajectory for maximal ablation volume, and really what I can really depend on is 12 millimeter diameter. So I make my stereotactic imaging 12 millimeters wide, and I try to fit it into that round structure. And I plan the trajectory based on a priority list of this little table. This is the list leading from what I will not go through, from what I can go through, of what I can make in my trajectory. And sometimes this matters when you're trying to optimize the heat. So I won't go through an artery or optic apparatus. Septal vein is, of course, a bad idea. But I have gone through choroid. I've gone through fornix and not injured it. Bottom of the sulcus used to be a no-go. Now it can be, as long as there's no big vessel. Superficial cortical veins are well tolerated. Corner of the sinus, I go through that pretty routine. I'm no longer afraid of the ependymal surfaces, although deflection can be a worry. Motor tracts are tolerated, and the sulcuses are tolerated. All the things we're taught not to go through in stereotaxy. In this particular scenario, when you need to, you can, with the exception of the first three. So the transventricular approach here is an example of how I've done that. I've gone through the ventricle here, and it was really optimal to get close to the heat sink at this very narrow portion of the third ventricle and maximize the ablation here. Here's an example of a heat sink down to the millimeter. I got a target here. I'm ablating at a relatively high dose, but here's the white heat sink in the thermogram. I back it up 2 millimeters and suddenly I can ablate. So it really is a matter of millimeters. So regrettably, this is an application of a thermal therapy without thermal planning. We can't really see where these things are, although there is some work going on in preoperative thermodynamics to see where we can find these things. Like for instance, on this thermogram, you can see that there's going to be a heat sink here. We occasionally see it, but I've usually gone for the strategy of drawing a diameter of where I'm going to be and go 1/3 closer to the heat sink to maximize my volumes. How you place the catheter is really up to you. I just would emphasize rigid stereotaxy in this scenario. I've gone to try titanium bolts, which I'll mention in a minute. I avoid any laser or surface registration that can slip. If you do need to study the hamartoma with an electrode, it's not a problem. The titanium bolts that are put out by PMT, I can just put the laser right down it. And I've been doing that lately on some suspects. I usually use ROSA as a guide, but I've used ClearPoint as well as a purely inside the MRI stereotactic system. I've evolved my technique over the years. I used to use a clear plastic bolt here that had to be put down a stylet all the way down to the target. I went to a titanium bolt shortly after that because it had a coaxial wrench and it was far more accurate in its placement. Drilling wise, I mean, any experienced stereotactic surgeon knows to avoid the walking of the drill and to go slow with low pressure and consider pilot holes as well. But walking the drill here can be a disaster, especially since there's long approaches. And the durotomy, I've changed my approach. I used to puncture it with a sharp stylet and I had some bleeding. So I now use Bovie, but you have to irrigate the skin if you're using the titanium bolt. If you don't, it looks like this. The plastic bolt will insulate the skin. The titanium bolt will not. So irrigate a great deal. So once you have your cannula anchored, you have to go down to the scanner and transport whatever you want to do to safeguard these is up to you. I usually manage this all by myself. And post-assertion MRI, we always get a volumetric MRI to find the cannula. The air in the cannula is very helpful to the MR techs. And I obtain at least one plane obliquely so I can see the whole thing in case there's trouble. And then I choose some axials in T2 to find the anatomy I don't want to ablate in the planes that I'm used to seeing them in. And that's very important because sometimes these oblique planes can very much skew your idea of what you're looking at the skull base. And then you start to do some continuous thermal planes in the, or continuous thermal sequences in the planes that you have chosen. So why do I choose these two planes? It's preferred. You can see more when you do two planes. One plane is the whole cannula, as I mentioned. The other is really seeing the anatomy, especially the mammothalamic tracts, because sometimes it can be pretty vague in the plane that you're used to seeing them go. And then one plane can be used in large ablations if you're in the middle of a giant one, but you really have to have a safe perimeter of 9 millimeters, and that's rare. I do a judicious use of low limit markers. When you use two planes, it's a refreshing rate of 7 seconds. So this is why I call it near real time and not real time. There's 7 seconds between the times that I'm going to take a look at this thing. I always adjust my lower limits down from 48 degrees. It does give you some wiggle room, which is very important. And I place the low limit markers at least 2 millimeters off the structure that needs to be protected in the direction of the heat source. On the high limit markers, I always have to use one to prevent the destruction of the catheter in case I have to go high and overcome a heat sink. The other one I use in the coronal plane, I use this as a drift detector, and anytime it goes below 35, I'll reset the phase. If one is used or borrowed as using a low temp, to preserve something to be structurally, for instance, I'm out of low limit markers on the current software and I want to protect another structure. I can borrow a high limit, but it must be watched at all times because this is not connected to the laser. It will not turn off automatically. Irrigation wise, it always has to be put together. A lot of the complications in early visuals had to be or were related to the poor use of irrigation. So what I've done over the years is I make certain I'm running my TMAP by the time I turn on my thermogram to be sure that I'm getting flow in all of the cannula. That's a good conformational check because sometimes your screw cap can be too tight. Sometimes the connections can be poor and leak. You have to see this happen before you're safe. And then I do test dosing. In this scenario, a 3 millimeter diffuser, I have to go up to about 12%, sometimes even higher at a 10 watt laser to see some of the heat. I let the refresh cycles go for about 3 or 4 times before I can get a stable thermogram and really understand this. Then I reset the phase just before the test does. Just as an aside, on some of the visualized systems, the older visualized systems, you're going to see this interlock thing. If you're frantically trying to press buttons here, you can sometimes hit this accidentally, which is very close to your slider. If you do that, then the laser will not turn off when it gets to your target, your low limits. So it's very important to check this to be sure that the interlock is always on. And then the ablation. I started about 50% of the 10-watt laser, and I watch the irreversible damage map, which is this orange structure created by an Arrhenius equation, looking at each pixel and knowing that a pixel at a certain time is going to be dead. We then change its color, and we watch this ablation map approach the edges of the hypothalamus. And that's when I cut it off, and I can put some safety markers on the other structure so I don't have to watch everything at once. You can increase or decrease the goal depending on this dosing strategy. If you have to maximally ablate a giant, I tend to use to keep my hot somewhere between 80 and 90 for about 3 minutes. That's my practical understanding of where my maximal ablation is going to occur, because you're really doing two things. You're putting in heat from the direct laser, and that's one mechanism. But the other aspect is you have a conduction heat that can go from one ablated structure to another, and I maximize that when my volumes are needing to be big. Here is one of those ways I do that. I'm always looking at the temperature map history, and if it starts to plateau, I know I can go up or down depending on it. Always keep the superimpose on, and I always have an anatomic split on. I do pullbacks about half the length of the irreversible damage map. And one thing I want to do on the pullbacks is be sure I'm right in the plane of where my heat is going to come out. And you can utilize this crosstalk, which is an artifact of the MR scanner when things go at 90 degrees, to know exactly where you want to put your heat, or at least where you're going to be seeing things maximally. So what does that mean? And then throughout this, I will repeat the process until the lesion is maximally ablated in a safe manner. So this is that crosstalk thing. So if I have my laser sitting here or here, I know that this is the crosstalk of the other plane in which I'm watching it. And I'm going to understand that I can really only see this effectively. I will not see this. I will not see that. So utilize this when you can see it. And here's a typical ablation. I've put some safety markers on these in this animation. You can see this is the one I use for a drift monitor, and I'll do a few test ablations to adjust. Here I know I'm a little bit low here, so I'll have to bring it up. If I move this along, I get to 50%, and you can start to see the lesion start to develop in near real time. And I maximize this as long as I'm looking at all the safety markers as I go. In the axial plane, this is where my safety markers are. Again, I'll do a few test doses. Let me speed it along here. A few test doses. You can see 4, 5, and 6 here. 6 was on the optic tract here, but 4 and 5 are in the contralateral mammillary body and the ipsilateral mammillary body. You can see them getting relatively close to the 48, but never quite over it. And when they do get over it, they cut off the laser. And that's how I make certain that everything stays safe. So what we actually see is this sequence here. Do a split screen here, and the anatomy on the left, thermogram on the right. And you can split the screen and see where the lesion is occurring, and a thermogram on this side in real time. Post-op imaging, I usually do a diffusion sequences and trace to see where the thermal ablation has occurred. This tends to overestimate my ablation, but it does give me an idea of some areas that I don't want to injure that are getting close. I do sometimes some T2 sequences to look at where the edema has accumulated as a marker, but the ultimate assessment is the gold standard of your ablation volume is a T1 with gadolinium. However, I want to preserve this until the end of the case because I can only give them so much of the contrast. This is my conformational imaging. This is T2. This is a diffusion scan inside the box here. And you can see it's a little bit shady. You can't really look at sharp detail, but you can get a general idea of how close you've come to the wall of the hypothalamus on this. This is the T1 infused on top of a T2, where I see the anatomy better. And this is, you can see that the infused scan is right up against the T2 scan. So that's an optimal ablation. And here's a superimposition of this one, where a T2 scan has a diffusion scan superimposed upon it, and the white is the diffusion. The really important part here is to be certain that the ablation, that the dome of these type 2 or type 3 hypothalamic hamartomas get ablated, because they can be the source of recurrence. This is the treatment summary: cannula inside, the irreversible damage map, and the infused scan showing a previously non-enhancing lesion enhancing. This is another technique that I would recommend if you're very, very worried about how close things are. You can do a 3-stack, what it's called. You can do 2 axials and a coronal. I can put some safety markers low where I don't want heat to go, but just in case it's getting to be a tall ablation, I can put it there. And I can put some more markers up here where the ablation is occurring. What's the advantage of this? I see more. What's the disadvantage? A 10-second refresh rate, which in laser ablation can be an eternity. So I only do this on the most complex lesions, and I wouldn't do this until you're practiced in doing a 2-plane approach. So we published our data in a few ways over the years. 93% of them are seizure-free at a year of the gelastics. Secondary seizures are a little bit more tricky, and over 25% of them can need more than 1 session. As far as our complications go, which is really the focus of this, over 149 ablations, I've had 2 children with memory deficits. 1 didn't get better, 1 is improving. I had 1 worsened pre-op DI. She had DI from an open approach before. It was a partial one. It worsened a little bit, and then it got better. So that was a temporary scenario. I've had 2 kids that I've needed to admit for cerebral salt wasting. One was a giant hamartoma that I did with 5 catheters, and the other one was early. It was a giant hamartoma as well, but it was early in my series. I didn't really know what I was dealing with then. Since then, I've been using a lot of just oral salt tab supplementation to get these kids out of their temporary but chronic, maybe a subacute kind of wasting scenario of salt. And it has worked out. I had 1 cranial nerve problem, a cranial nerve 3, and it got better over time. And I had 1 temporary upgaze problem from the volume change in the hamartoma. This is an example of the low limits where I put them to avoid the mammal-inflammatory tract, and sometimes it does not work, but this is an example. This is when it doesn't work. It gets a little close, and this child had a memory deficit, so even if it doesn't involve the lesion, getting too close is a problem. And this was the first child we had with postoperative MRI. You can see that the mammillary bodies bilaterally have a signal change. I looked into the literature when that first happened. I realized the average of the 1 millimeter cutoff is truly that. It's an average, and sometimes it can be quite higher. So that's why I've gone to 2 millimeters being off of this, putting my safety marker 2 millimeters off the structure I want to preserve. And of course, looking back in the literature, I realized that there's a lot of understanding of how big these things get when you immediately ablate them. This is Shabar-Danish's work looking at the immediate volume change that can occur from not only epileptic lesions, but tumors as well. So be very wary. This is what the preoperative steroids is there to fight. So the diabetes insipidus is the child that had a preoperative structural problem. When I ablated the volume, it did stretch the stalk, which is sitting here. This is the child, a very large ablation that had the salt wasting problem. It required 3% in the hospital. Also, I want to mention the iterative approach. This is a large lesion, very complex lesion. And over time, this lesion was approached in a number of ablation phases over the child's lifetime, and ended up with starting with this structure. Here's 1 ablation, here's the second, and only had this tiny little sprig. And after a while of figuring out why this kid was having very minor but still persistent gelastic seizures, we proved it that was the source of the seizures by ablating that tiny little area, and now has been seizure-free. So this heat sink issue and the iterative approach really has been able to maximize the treatment in some of these children with the giants. And this is a giant hamartoma here. It's almost amorphous, but over the time we got ablating it, we were left with this bridge. He actually went to Japan to get this RF ablated and is cured. Other limitations. So both too large and too small lesions can be a challenge in laser ablation. Sometimes these lesions are very broad-based. They don't have a very clear connection. So you'd have to do a laser going down one side to ablate and disconnect that, a laser going down the other to ablate that. And I did this in stages. Any lesion greater than 2 centimeters is going to need more than one catheter, and you can do that in the first session if you want. Always look for the heat sinks. Here's some of the flow voids that are occurring in a child's increased pulse pressure, or increased pulse with CSF turbulence, and this is going to be a heat sink, and that's going to be a heat sink. So it's always good to gauge for them. And also sometimes the hamartoma can be so small that you can't get temperatures in it high enough that don't injure the surrounding structures. Twice I have put a catheter in a very small hamartoma and have been unable to achieve ablation temperatures because it's just too physically close to the fornix or the hypothalamic wall. So in conclusion, I think laser ablation is well suited for surgery in the hypothalamus. It's a corridor related, it minimizes the corridor related morbidity. A judicious use of these low limit markers and low power can prevent a lot of injuries to the memory circuits in the hypothalamus that can occur in the open operations. Above all, I think it requires a paradigm shift in the thinking of the surgeon, where we need to abandon the one good surgery approach and think of an iterative, accurate ablation for each session, knowing that we can come back and touch it up. And that I will stop.
Thank you very much, Dan. As usual, we just continue with the second talk given by George Dorfmüller, and then we have our discussion after that. Please, George.
George, we need your audio also still.
Georg, you have to unmute your mic.
Okay, you hear me?
Yes.
Do you see my screen?
Yes.
Okay, thank you. So thank you for the invitation to speak about our experience on hypothalamic hamartomas at the Rothschild Foundation, which has a history which has begun in the end of the 1990s. As you know, hypothalamic hamartomas are a special disease. In a 2004 survey of the ILAE, 3.6% of the neurosurgical pediatric epilepsy procedures were dealing with hypothalamic hamartomas, and in the extension it went up to 6%. So it's a small number, but significant in each center which deals with pediatric epilepsy surgery. So these cause gelastic seizures in the beginning, mostly, and later go on to multiple seizure types, and they can be devastating over the years, especially when they're larger volumes, by causing cognitive and behavioral decline, leading to progressive epileptic encephalopathy with secondary epileptogenesis, which will be more resistant later on to medical therapy or even surgical approaches.
Georg, very sorry to interrupt. There are people saying that cannot see your slides adequately. Could you unshare and share again, just to try to see
Yes,
this?
of course.
Thank you. Okay, thank you.
Is it better? Yes. So it was in the 90s that we knew that elastic epilepsy would be at the origin, hamartomas would be at the origin of galactic seizures and secondary encephalopathy by SEG recordings in Grenoble, and later on by Ichthel Specht, this was confirmed. Hamartoma resection was already presented in the 60s for precocious puberty, and Payas in Marseille presented the first series dealing also with epilepsy. It was a nice paper at that time, but it was, as I said, in the mid-90s that we knew exactly that the epileptic foci on EG and the semiology was due to the hamartoma as the origin. Stereo radiofrequency thermoablation was first proposed in a case in 1999 by Fukuda, and later a series appeared. Regis started presenting gamma knife radiosurgery first in a multi-center study, and later on in Marseille with large numbers. Jeff Rosenfeld proposed the anterior interfornical transcallosal approach to the third ventricle for resection of hamartomas. And Olivier Delalande, my mentor, and Martin Follen, our neuropediatrician, published in 2003 two papers on the endoscopic, the first papers on endoscopic disconnection of hypothalamic hamartomas. And Dan just presented his excellent series, which was starting in 2013. So the idea of our technique was to access to the hamartoma, the third ventricle, mainly in one-sided attachments first, by the idea that disconnective techniques like another techniques as hemispherotomies or multilobar resections could also be effective in stopping the seizures and not only dealing with resection. And what we do and did since then, we do a thermocoagulation with a thermocoagulation probe and a series of thermocoagulations in the anterior and then the posterior margin of the attachment of the hamartoma to the ventricular wall. And then later what I do, I try to distract as much as I can, if the endoscopic situation allows, from visibility in other rows, the hamartoma itself. And it depends on the depth, and we have here preoperative MRI, and we calculate the depth where we can go with the thermocoagulation or laser probe to do distraction. And we, of course, you have the mammillary body and the floor of the third ventricle, tuberous cinereum, and the recessus, infundibulary recessus. And so we calculate this by preoperative high resolution MRI, and we have our robot planning software, which allows at every inclination perioperatively to see how deep we are and what is the depth of the hamartoma. Anatomy is important of the floor of the third ventricle to anticipate complications and to explain, as Dan explained, several anatomical parts. Here you have the mammillary bodies, the third nerve on the both sides, the floor of the ventricle, and the tuberous cinereum, pituitary stag, and of course the vascular situation, which is quite dense in the posterior interpeduncular cistern. So this was just shown, the characterization in 4 types. Olivier Delalande proposed this for a practical reason, to see which cases could be amenable to a disconnection from within the ventricles. And of course, the type 1 is, has a horizontal, completely horizontal attachment to the hypothalamic floor on both sides, and an endoscopic approach makes no sense. And there is a type 2 with a vertical, type 3 with mixed attachments, and the large type 4 hamartomas we just saw. This is type 1 hamartoma, which has a complete horizontal attachment. And in these cases, what we do a pteryneal craniotomy to access, but in fact, the posterior upper end of the lesion is not easily approached. That's why several teams offered orbicozygomatic approaches to ameliorate the angle, to better have a visibility of the posterior part, but it remains mostly incomplete. You can do debulking of large portions, but you have not infrequently a posterior part which remains. This is type 2 hamartoma with a more vertical attachment, the type 3 with a vertical component and a more horizontal, another type 3, a large hamartoma which has more vertical access, but the problem here is that you have very few space to work with the endoscope. I will show a picture later. So this is our technique with endoscopy. I will show this later, where you have the anatomy, the anterior commissure, the fornix, the ventricular walls, and the attachment of the hamartoma, which is one-sided. So you do thermocoagulations by going down with a temporal probe. Where do you go in? Where do you choose your borehole? It's important to prolong the angle from the center of the hamartoma, the Monroe, and the entry point, because we need to have the least possible shear forces to the foramen of Monroe when we move the endoscope anteriorly and backward. And you can go quite laterally if you see the attachment, but for hamartomas where we're not sure they are perhaps both-sided attachments, we try to go as medial as possible in order to be able, and we can do this without problem, to bend the endoscope vertically and to have a visibility on the ipsilateral side. This is the endoscope we use. Usually it's a DEC endoscope from Storz, which is a classical endoscope. And this is the endoscope we use when we use the Cavitron ultrasonic for ventricular. The problem is the operation sheet is 6.5 millimeters, which is quite big in children with small Monroe. So I personally prefer to do this, and this is one of the reasons we do much less CUSA interventions in the third ventricle, except if the ventricles are large. This is a preoperative planning on the ROSA software, and here I do a burhole chipination in order to centrate the burhole, and then we install the optic system, light source, etc., which is classical. These are the thermocoagulation probes. We use mostly the smaller one to do the disconnection line. In the last years, we use also systematically the Fogarty catheter to, if you have done the disconnection, to spread off the hamartoma from the wall. And this is the thulium YAG laser, which we use also to disconnect. So this is a film with thermocoagulation. You enter the Monroe, see the fornices, and here you have a connection on the same side. This hamartoma is connected only unilaterally. What I do, I coagulate the surface, and then I don't coagulate when I go forward to the depth, but I go forward to the depth, reach the inferior point by measurement, and also by feeling, because the capsule of the hamartoma, the lower capsule, has some resistance. And what I do, I go down, and then I go up 2 millimeters, 2 millimeters, and then I start coagulating by drawing the monopolar probe upwards and not inverse. Usually, as you see, there's a lot of small bleeding. Hamartomas are hemorrhagic, more or less. There are different types, but of course, we do regular perfusion and endoscopic perfusion into the ventricle systematically and to ameliorate the images. But sometimes the visibility can be impaired, and this can sometimes need to stop prior to finishing a procedure. Here I have the posterior part, just above the basilar artery, quite close to the midline. So we choose a less depth, and here you see a disconnection. And then I go and do the same thing in the midline on the specimen for the pathology. So this is a same procedure with another type 2 hamartoma, this time left-sided insertion. And here we use the thulium laser. So you see anatomically, you see the anterior chiasmatic and infundibular cisterns. This is the left-sided attachment. And I start doing holes. And then because of the rigidity of this instrument, I can draw a line, a cleavage line, better than with the probe, which is more elastic. After having done this, I enter the Fogarty probe to open the balloon. I can't do this if I have just one hole of coagulation, because this would damage structure. You need quite a row of disconnection line in order to put the Fogarty balloon, and this will spread the hamartoma apart, and you see the depth below, the cistern below the hamartoma. And here again, the specimen for anatomopathology. So this is the huge giant hamartoma, type 4 in the classification, and we did it a few times, but it is frustrating because when it goes up close to the fornices and the anterior commissure anteriorly, you don't have space to go with the endoscope, and you cannot see these attachments which you appreciate on MRIs, coronal MRI, but you simply don't see them, and you need to debulk the tumor. So for purely endoscopic surgery, this is not a good indication. This is a case of a 7-year-old girl who had a type 2 hamartoma with very frequent elastic seizures, no other seizure type, and normal development. We did endoscopic disconnection. You see the difference MRI before and following. You see the disconnection line quite well, and a form of atrophy of the hamartoma, and she's still on clobazam, but she's doing much better, no deficits, and she describes very infrequently some inner urge to laugh, so a sort of aura. This is another case of another girl with a left-sided larger type 2 hamartoma with a normal development, but beginning behavioral problems and tantrum fits. She has equally a lot of elastic seizure, but she started having complex partial seizures, which were quite well controlled by medication. And we did a first disconnection, which was satisfactory from the MRI aspect. You see the disconnection line here on the insertion on the left side, and but she was seizure-free for 2 weeks and then began progressively having seizures, the same frequency, the same seizures. So we did the second procedure, and this is the result of the second procedure. Again, a success from the MRI image. You have a shrinking as compared to the initial hamartoma, and the intraoperative aspect was satisfactory, but she was again a few seizures free. She has no elastic seizures anymore. This is one advantage. And the other thing, the parents noted the behavioral progress, but she's having quite a lot complex partial seizures with staring, arrest, movements, head movements. And she has about, on the mean, about 5 seizures a day. So we are thinking of redoing a third surgery in order to destruct perhaps with the CUSA, endoscopic CUSA, the rest of the hamartoma at the base. So this is just a case of a boy which was operated a year ago. And you see here, this is a redo surgery. We go again back. It was one-sided. The left side was not attached, and we will do a second disconnection. And what was astonishing that we found an attachment on the left side, sorry, the left side and the right side was disconnected. The left side was free. And on the images, you see the hamartoma of before and after surgery, which some reduction of size, and still nothing on the left side, of course. And when we started doing disconnection on the right side, we saw that this attachment was very superficially. So I believe it was blood products intraoperatively which caused the very superficial attachment. Below, you see that this hamartoma is still one-sided. This boy had a good result. Another atypical aspect, the girl with the left-sided type 2 hamartoma, which is bending below the floor, and some small attachment. We didn't notice that too much. And the intraoperative picture showed an image which was strange to us. Of course, we insisted that this was the side of the connection on the right side, but this seemed to be a pseudo connection, which corresponded to this small breach. And so we did the connection on the right side to the midline, and the outcome was favorable. In our series, we had 136 patients, 112 children in the 20-year period, and the mean seizure onset 23 months, mean surgery 11 years. But if you take out the adults, the mean age of surgery was about 7 or 8 years. Of course, most of the kids had elastic seizures, but quite a few had 94% were associated with other types of seizures at the time of surgery. 212 of the 232 procedures were endoscopically, 70 patients had one surgery, 66 had multiple surgeries. Quite a few, as you see here, this is important. At the moment, the time of diagnosis and surgery have already comorbidities, cognitive, behavioral disorders, more than half, memory deficits, more than a third, obesity, endocrine disorders, close to 20, and precocious puberty, 14%. So how about our complications in our series? We had, our series has more complications than what Dan showed you. We had transitory 4 memory deficits, 9 oculomotor palsies, which completely regressed, 3 facial palsies, 2 meningitis, 2 diabetes insipidus. We had 7.3 permanent deficits with memory deficits for other kids, oculomotor palsy, motor deficits, which partially recovered, and weight gain in 5. Complication rate for the larger type 3 hamartoma was somehow higher with 11%, which is logical. This surgery needs more time, and the space of disconnect, the line of disconnection, the procedure is longer, and no difference was in morbidity noticed if you had first or repeat surgery. And this is also to say if you'd go for a second or a third time, surgery will not be more difficult than after first surgery. This is the results we had of the type 2 hamartomas. We had complete seizure-free 67 children on long-term follow-up. If you take the ones with rare auras, we had 83% with very favorable outcome, and in the type 3, 47 were seizure-free and 68 had a very favorable outcome. And of course, the outcome of the gelastic seizures was even better with 90%. We did some logistic regression statistics, and what comes out from our series is that the time from seizure onset and or diagnosis to surgery, a shorter delay is a prognostic factor for a favorable outcome, reducing the risk of developing a wider epileptic network at encephalopathy and secondary epileptogenesis, which complicates things later on. In our pediatric series, the delay from diagnosis to surgery is a predictive factor for good outcome. So children without developmental delay have a better seizure outcome than those who had at the diagnosis a developmental or behavioral delay. But this should, on the other side, not exclude, of course, these children from treatment. And what can you take as a message? The best indication are interventricular type 2 hypothalamic hamartomas for endoscopic disconnection. Partially interventricular type 3 hamartomas are also indication, but the seizure outcome is inferior. Bilaterally attached hamartomas and large hamartomas should better be operated in more than one stage. We don't hesitate to operate children in 2 or even 3 stages when the hamartoma is large enough. And second or even third endoscopic surgery is efficient with the same approach, and there's no elevated morbidity with repeat surgery. Pitfalls are a longer endoscopic surgery. This is personal experience. This is not in our statistics. We didn't look for that, but longer endoscopic surgery duration and with more extensive tissue destructions seems to elevate the morbidity. The duration and completeness of procedures can be impaired by reduced visibility, as I told you before, with slightly hemorrhagic CSF. Giant type 4 hamartomas prevent through their size from visualizing, especially the upper growth, from visualizing well the attachment when you enter the Monroe. And so for us, disconnective procedures have no place in these very huge hamartomas. Thank you very much.
Thank you very much, George, and thank you, Dan, for 2 really excellent talks. We have some questions from the audience. So one is regarding radiosurgery to control seizures. Maybe, Dan, you can address this question first.
Yeah, it's a good question. Where does radiosurgery fit into our treatment? Arma, into the whole options here. I think that that's an important consideration. What George mentioned at the end was outcomes are based on how long the children have endured the epilepsy and how quickly you're able to stop it, at what age, and the magnitude. So in that regard, the radiosurgical approaches have two major drawbacks in my opinion. One, size. So giant hamartomas aren't an option. Only the smaller ones can be an option. You may be able to do multiple foci, and that's fine. And then time. The biggest factor is time. Radiosurgery takes a while to happen. Some of the published outcomes are 18 to 36 months. It may be quicker than that in many kids. Nonetheless, we think we're going to have to wait for an effect. And if you wait on a kid having 10 gelastic seizures a day and developing an epileptic encephalopathy in front of your eyes and having developmental delay, that's probably not the best one. But if you have a teenager, honor student, totally normal, where the morbidity of a more definitive approach would be highly impactful, then I think trying radiosurgery first, if you have time to do it, is a good idea. And I have recommended that on some of the kids that come to me, say they're 14, 15, they didn't notice, or for the longest time, one of the problems with hypothalamic hamartoma, it gets ignored as a diagnosis, and it only becomes an obvious epileptic syndrome when they have a non-gelastic one. And sometimes that happens in their teenage years. And if they're functional, then maybe radiosurgery is the best approach on those kids to see if you can get that outcome. It's not as efficacious, but it's incredibly safe. Jean-Regis series shows very, very little morbidity to RF. So, I mean, to radiosurgery. So I think in those scenarios where you have to be maximally safe and it's a minimal impact, I think it's a good idea. Short of that, an infant with developmental decline, I think it's probably not a good pick.
Yeah, thanks. George?
Yes, I fully agree. I think with endoscopic surgery and with laser ablation, you see immediate effects. You see the child. It sounds caricatural, but you see sometimes the child the same evening on the awakening room or the next day changing in behavior. The parents notice this. You have the immediate effect. You don't have that. You have these long delays. But of course, complication rates is not an issue with gamma knife. They are careful, and they have titrated their dosage. And I think an older child with no cognitive impact and fear of surgery, and perhaps also positioning, which is for us has higher complication rate. This could be an option. This could be an option for gamma knife surgery.
Thanks. And then I have a question with regard to the trajectories. So for the endoscopic approach, you always have to come through the ventricle. Do you see any advantages or disadvantages? Because with the laser, you always come from outside the ventricle. Are there any advantages, disadvantages, issues from the trajectories that you can offer? Maybe George, to start with.
Yes, we are limited by the foramen of Monroe, but we have to calculate preoperatively. We have to see the MRI scans, sagittal images, coronal, to see if we can approach. In a few cases, I remember having been performed through a burr-hole and disconnection, and it was a large hamartoma, and they needed a second surgery with a trajectory which was behind. But this is quite exceptionally. Regularly, we can, with hamartomas, we do disconnect. We can reach from one trajectory.
Yeah. Another question, maybe to the panelists. Now that we have heard two excellent talks on minimal invasive techniques, is there any role for open surgery? Maybe George, you told that, so for type 1, you use the prenodal approach. Are there any cases where you use an open approach, a transcallosal approach?
We have a reputation for endoscopic surgery, which de Lalonde started in '97. So when I arrived in 2002 and his team, and I learned all the technique from him, we had quite a lot of patients coming from France and from abroad. So we are known as being one of the endoscopic centers. So indeed, we have rather few experience with open surgery, with skull-based surgery. I have started operating as well as Olivier at that time. He tried to disconnect. I try rather to resect them. If I showed you an intraoperative picture, but surgery is quite invasive if you want to perfection to ameliorate the angle, to go further behind, and it's clear that you can have complications. You have perforators, you have all the neurovascular structures, and if on long-term laser proves its superiority, I think we should leave these parts to the laser approach instead of open surgery. I was impressed by the huge hamartoma you showed, which you did in 3 stages or 4 stages. This is impressive, and if this is may become a gold standard for these enormous lesions, I think perhaps in the future open surgery has less place. What we do when we do type 3 hamartomas, and with a portion below, of course, it's our patient, and we propose a craniotomy and resection of the inferior part. So the philosophy behind is to try to disconnect first everything which is within the ventrically attached to the wall, and then in the second stage to try to do per craniotomy to try to resect the inferior part.
I agree with those. Can I make a comment on the open? I think that it's important for us to realize that these techniques tend to be relatively hyper specialized in small centers, and an endoscopic approach in George's hands is a totally different ball game than an endoscopic approach in my hands, and the reverse is true. I think this disease is so rare, and the complications of both inaction and action are so devastating that I think it's one of those disease processes in which we need to be very open to noting that we should send them to various centers. I've had a number of radiosurgical consultations, and if they can go to some place that does it a lot, I will send them. I will give them contacts. If I have an open approach that's needed, or they want to consider it, I think going to somebody who does it a lot is a good idea. I think that we need to keep in mind that not only does technique matter, but the comfort level and the experience of that particular surgeon matters as much. And so being open about that sort of consideration, I think, and granted, maybe not all options are going to be available to your patient in your community. And if they can't get out of their community, you're going to have to do the best you can to combat the epileptic encephalopathy that these children suffer from. But always keep in mind, you don't want to be worse than your disease. So if you can palliate, that may be enough for these children, as opposed to going for broke and devastating them for the rest of their lives. So it's very much risk-benefit calculation in the context to your particular geography.
Fully agree. Thank you for the comment.
Christian, there's a couple of questions. I don't know if you see from, do any of the panelists have experience with SEEG, radiofrequency thermocoagulation? Dan, I know you mentioned and you showed a case where one of your patients actually had the very last part of a giant hamartoma that they went to Japan for radiofrequency thermocoagulation. And can anybody comment on that a little bit in terms of a very specialized technique?
Yeah, I think the two are a little bit different in the sense that I think the questioner is referring to the notion of doing a stereo EEG to study the seizure network and then simply putting RF signals between the active electrodes. Because of what Christian mentioned in the very beginning, that this is a very obvious epileptogenic zone, and that we don't have to do a lot of stereo EEG in these kids. There's not a big series of this. The only series that I can tell in the literature that's really addressed this is from China. And I only think they had like 9 or 10 patients. And their success rate, I think, from remembering correctly, is somewhere around 55 or 60% in doing that. ablating those electrodes within the hamartoma itself. Obviously, the complexity of anatomy and all that are going to factor in there. Not to be confused with the very large, well-published, well-designed Japanese literature of RF thermocoagulation in hypothalamic hamartoma. That is just using the RF thermocoagulators we've done for functional neurosurgery for decades and applying that to a very carefully designed stereotactic approach. And that's about a 3 millimeter ablation length or volume, 3 to 4. So they have to do multiple ablations in multiple tracks. In that scenario, there are some complications, cranial nerves, hemiparesis, things like that. And I think a lot of that has to do with the fact that they have to do so many tracks to get some of these disconnected, because the volume of the RF ablation is so small. It was designed for movement disorders. It's designed for a good 1 to 2 millimeter lesion, and doesn't really match up with the vast majority of hypothalamic hamartomas. But in their hands, it's done well. They've had well over 100, and they have an efficacy rate of somewhere around 80%, 85. So they do a good job. There is some side effects from the multiple tracks, though.
So I agree with Dan, and there is a confusion because when there's no place for SCG in pure hamartoma pathology. What we did in our center, we did in a few cases with double pathology when you had another focus on MRI. We did double SCG implantation. We implanted in the focus and in the hamartoma. But the purpose was to see what's coming from the hamartoma, what's coming from the focus, from the dysplasia outside the hamartoma. But the implantation of the electrode within the hamartoma was not with the purpose to coagulate later on. Coagulation of hamartoma with the SCG electrodes has no sense. Indeed, if you do it as the Japanese proposed it a long time ago with the thermocoagulation series. We saw the nice presentation of Sarat last 4 weeks ago, where he did the hemispherotomy with almost close to 100 trajectories. If you plan to do a disconnection of the hamartoma or destruction, you do it differently than SEG planification.
Jorge, you wanted to comment?
No, I think the panelists, the speakers, Dan and George, answer. My question is, there has been increased evidence of dual pathology in hypothalamic hamartomas. And I wonder how the surgical management change when you have a patient with a structural lesion in the hypothalamus that suggests a hypothalamic hamartoma, but it has no typical seizure semiology or electrophysiological correlations related to these hypothalamic hamartomas. For example, hypothalamic hamartomas with temporal lobe seizures. So is there a role for an SCG exploration, or you will go directly to ablation of the hypothalamic hamartoma in those cases where the semiology does not quite fit the structural changes on the MRI?
That's a great question. And yes, and yes, I guess would be the answers. Mainly as a reflection of the fact that we really haven't figured out how best to handle this scenario. I think a few questions come up. One, how accurate and how reliable are we on the semiologic assessment of the patient? Sometimes in our kids, they can't tell you what's going on. If they feel a laugh, feel like they have to laugh or something like that, you'd never know. If there's an obvious gelastic component to it, then that's where we will focus without necessarily a stereo EEG. But what if there isn't? What if it's temporal lobe, which we know by connectivity studies is very much connected to the hypothalamic hamartoma, especially, and also the mesial-frontal? Well, what do you do with that? I've approached it in a number of ways, and there's no consistent pattern of success. We've done stereo EEG on those kids, and it guides us to, say, a cortical anatomy thing. We do a temporal lobectomy, and they still seize. And I do a post-ablation or a post-resective stereo EEG, and what do you know? Now the hamartoma is active in an obvious way. I think where you put the electrode in these hamartomas is important. I think Howard Cates' work and And G's work and the histologic anatomy of these structures tells us there's some areas that are very epileptogenic and some that are kind of inert. And if you don't put the electrode in the right spot, you're going to get fooled on a stereo EEG. So I wish there was clarity. I'd like to hear what the rest of the panel has in this experience. But I've gone down the road of not treating it and always regretted it. I've gone down the road of treating it and only regretted it once.
Yeah, let me ask both of you regarding the pathology of specimens. Is there a difference in patient management if you have a biopsy or not having a biopsy? Do you foresee any future difficulties or not? In LIT, you don't have a biopsy, and if you go endoscopic, you can get a biopsy. But is there really a need for a biopsy? And after that, I would ask then to elaborate on the physical differences between the lesion generated by LIT and by radio frequency.
I think with the clinical semiology and the imaging, it's quite clear that it's a hamartoma. It's rare that we go into the endoscopy thinking it could be another kind of lesions. We were almost quite sure. Doing endoscopic surgery does not take much to put the biopsy needle in or the biopsy tool and get some tissue out. This prolongs not the surgery. This has no complication rate, and you have a pathology, which is, I must admit, always the same. So it's no surprise. Recently, we participate in a genetic study, and we take some tissue out. But this is another issue. This is research. But no, it doesn't bring us more information, but we do it because we are there, we see the hamartoma, and we profit from getting some tissue out.
Yeah, same way with us. A biopsy of the hamartoma doesn't help us in a clinical manner, and we have some research protocols that are looking into it. Biopsy in a true core stereotactic biopsy in laser ablation of hamartomas is fraught with difficulties because the possibility of introducing air will ruin your ablation. You will have a very tough time controlling for that air bubble. So it's not the sort of thing I like to do. So I don't do it. I have, however, noticed that my Christmas card volume dropped precipitously with the advent of hypothalamic hamartoma from all the researchers in the hypothalamic hamartoma centers that were studying these tissues and really understanding a lot about the unique epileptogenicity and pathology of these. Like they're gap junction mediated, and there's areas of high cell and areas of low cell, and all this fascinating stuff, which has been stifled since the advent of laser ablation. What we have looked at, and luckily I was in a center in which one of my adult colleagues, physician scientists, sorted out a way of getting a DNA profile from the cells that are in epileptogenic lesions of stereo EEG. Alicia Goldman's lab sorted out how to take the stereo EEG electrodes out, wash them, and get cells for DNA analysis and sometimes RNA if they're fast enough. And so the understanding that we may be able to know something about these diseases in the future from a DNA sort of approach is an interesting research notion and may open up some avenues, similar to how we kind of shot ourselves in the foot by not biopsying DIPG in pediatrics. And we were 15 years behind the molecular understanding of that tumor by the time we finally caught up. And now there's developing molecularly based chemotherapies for those kids. Same idea for hamartoma. And we're probably going to get that data, en masse in about 4 or 5 years. But short of that, biopsy is not a clinical indication for us. In fact, it decreases our ability to treat them with thermal ablation.
I think, Dan, as you're saying, this is one of those areas where everybody wants to have the tissue to be able to look at the various research aspects, but the patients and families are going to drive towards the procedures that they think are safest that may limit that ability. Yeah. Dan, can I just go back to the question that Jorge was asking just to clarify, because I want to make sure that what you said that I interpreted correctly. So if somebody is not clearly a gelastic epilepsy, but has a hamartoma, as well as maybe a suspected area of temporal dysplasia or just suspected temporal seizures, you know, as we know, sometimes these cases are very hard to localize. Are you saying that if now in your recommendation or your practice, would you treat the hamartoma first to take it out of the equation before doing a stereo EEG in that sort of patient? Or would you do a stereo EEG and lean towards treating the hamartoma first? What are you actually doing in those patients?
Yeah, so sorry, I wasn't very clear. We're actually in the last points of publishing our series of HH plus kids. And we do know that when we treat them just by hamartoma ablation alone, we drop our efficacy considerably. We drop our efficacy into the 60s. So there is a need on these children with hypothalamic hamartoma and some other structural pathology to consider a stereo EEG approach first. What really has driven us in the past, though, has been semiology. So if there is any evidence, whether it's a smirk or a urge to laugh, I will still think that we need to ablate the hamartoma first and then deal with the recurrences later. But if there is a non-gelastic semiology and there's another lesion, then we have gone to stereo EEG on those kids, or at least will in the future. They're pretty rare. And examining the HH plus kids has really changed the way we protocolize it. And I think in the future we will be, if it's a non-gelastic semiology and another lesion, they have to get a stereo EEG before we can be conclusive as to what to go after.
George, what are your thoughts on that? The same?
I don't think that 100% of the kids with hamartomas do have gelastic seizures. Some kids might have had, some have been unnoticed by the family. We have patients who said they started with a generalized seizure at 11 years or 12 years and nobody noticed. And this was the hamartoma at the origin, which was proved by surgery of the hamartoma. So if there is no lesion with a high resolution MRI and a good neuroradiological diagnosis, I'm not sure EEG brings us further. If there's a typical repeated over years semiology, very stereotyped semiology, extra of a particular lobe or region, then this could be discussed to do effectively a stereo EEG method. The few cases where we had SEG because we thought there was something outside the hamartoma, we ended doing the hamartoma surgery first. I don't think we ever did a stereo EEG and we got to a lesion and left the hamartoma behind untouched. So I would go to do the hamartoma disconnection if it's accessible, if it's not a complicated one, first. If there is no lesion on MRI, on high resolution MRI, after following a staff analysis of EEG. But in the past, in the history, EEG has misled us. Don't forget that in the late 90s, some teams did corticographies, cortical resections outside the ventricular wall, cortically, and without any success.
Yeah, it has a long history of being in the wrong lobe. And we're all worried about it. Nonetheless, we were so driven by findings of intracranial recordings that we thought, oh, this must be the exception. And we've regretted it more than we don't.
Jorge, you asked the question, but could you share your opinion on the issue?
You are mute.
Yeah, got it. So I think it's very controversial, and I agree with George with them. You know, not all the kids that will have the typical gelastic semiology, and the presence of epileptogenicity or questionable epileptogenicity in the temporal lobes is not unusual in the hypothalamic cases because of the connectivity with the Papez circuit, with mammillothalamic tract. So it's a tough question. I think the approach can be, there is no right or wrong, and those cases are rare, but the perhaps more pragmatic approach will be treat the hamartoma if the patient continues having seizures and then explore And the other approach is to do the SEG first. I have the impression, and our experience with this is maybe we have perhaps 3 or 4 cases. The SEG interpretation is quite difficult. And in the cases that we end up doing the exploration, we end up treating the hamartoma initially and then follow up. And if the patient recurs, and then treat the other areas. The problem with the recurrence is that if you do an incomplete disconnection of the hamartoma, and then the patients recur having seizures, and then we are in a difficult situation. Is because the hamartoma is incomplete disconnected, and you should go back to the hamartoma, or is because it's coming from an extra hypothalamic focus. And I think those are very difficult cases. Fortunately, I think those cases are rare. I like personally the pragmatic approach of treating the lesion, and if the patient recurs, probably an SEG would be probably more effective. Those are my thoughts. There is no right or wrong, because again, the cases are so rare.
Okay, so any other questions, comments from the panelists?
On some of the questions that didn't get addressed, should we take? I'm going to type out a response. Is that Is that how you want to do that? Okay.
But before that, would you follow up on elaborating on the difference of the physical difference between the RF and the laser ablation lesions themselves?
Yeah. So the RF lesion is usually quite high. You can turn down the settings if you want, but it's typically beyond the laser temperatures, and it frequently creates gas. It's smaller though, on the order of 3 millimeters, maybe 4, if you really maximize it. Problem is, once you get to that gas formation ablation level, it's hard to predict where the damage is going to go. A couple of people have tried to get around this by making longer and directable RF probes, like the check group for the temporal lobe, but nonetheless, you're stuck with that volume problem. Other than that, they behave very similarly in the sense that they still have the heat sink issue. They still have a proximity issue. I think that one of the reasons why RF ablation, which was done blind by dosing by a prescription, was so low efficacy, is you really couldn't see where the heat was going. And with a thermogram now, you can see where the heat is going, and you can dose it appropriately. You can't direct it. The Monterra system says they can direct their laser, and that's true, but it only lasts for about 40 seconds. And then you got to circle again, because heat itself, due to conduction, is not going to be a directable thing. So I think the main differences are size, controllability, and gas formation, I think, are the 3 big issues on RF. I mean, RF, in some of the older days would be applied by surgeons until they heard the audible pop, and that it's definitely a gas forming thing.
Okay, then I think we are now 25 past 5, and if there are no more questions or comments, then I think we can close it for today. The next session will be on December 13th, and it will be on tuberculosis complex.
Can we keep it up while we type out our responses?
Hey Dan, we'll forward any other specific technical types of questions directly to you, and then you can answer them, and then we'll send them out by email.
All right, great, thanks.
Okay. So bye-bye.
Thank you. Bye-bye.
Thanks, everybody.